Welcome to Dr. Gor Show. Today our topic is leg pain. Is it PVD? So there are a lot of different causes of leg pain. PVD, which means peripheral vascular disease. If the cause of leg pain is because of PVD, it can be a little bit worrisome. To talk about this very important topic, we have Dr. Anuj Shah in the studio. Welcome to Dr. Gor Show.
Thank you, Dr. Gor. Thank you, Hetal.
So, Dr. Anuj Shah started his career in Ahmedabad, where he went to medical school. Then he went to University of Connecticut. That's where he did his residency as well as training in general cardiology. Then he went ahead and did interventional cardiology at Mount Sinai Hospital in New York. Dr. Anuj Shah is practicing in New Jersey at 3 different hospitals. So, PVD, peripheral vascular disease, as the long full name, means that there is some clotting of the peripheral vascular tree. When I have to explain to somebody, I would say it's like blockage, similar to the blockage in the heart vessels. Heart vessels, when they shrink, they give you heart pain. Similarly, when the vessels in the legs, when they shrink, they give you leg pain. Is it similar way to explain?
Yes, thank you, Hetal. So it's actually exactly how you described. There are multiple names: PVD or peripheral vascular disease, PAD or peripheral arterial disease. Basically, it's a blockage formation process.
Correct.
Now, what most people don't think about is this blockage formation could be from something called plaque, which is hardening your arteries. Your arteries become very hard and very calcific and leads to something like a plaque, which is blockage,
Correct.
debris built of cholesterol and calcium. Or it could be a clot. A clot, in turn, is a more acute process that happens rather
Correct.
dramatically and rapidly.
Right.
And that could actually lead to one of the more severe form of, or more rather urgent form of peripheral arterial disease. But the majority of the PAD we see, which is very comparable to the blockage formation in the heart, is the peripheral arterial disease with plaque formation.
Correct. So in the heart as well, right, we have blockage of the coronaries, can be because of the cholesterol. That's why we control people's lipids to control the cholesterol formation, because then that puts at risk for the blockage and the calcium deposition. Now, is there a similarity in the age group with the presentation?
Absolutely. So, they are very similar disease with the same vascular tree. We always say it's the same vascular tree.
Correct.
The same factors that lead to blockage formation in the heart and coronary arteries lead to blockage formation everywhere else.
Right.
So the same risk factors lead to blockage formation leading to strokes.
Correct.
Which is blockage formation in the
Carotids.
carotids and also in the cerebral blood vessels.
Right.
In the aorta, which leads to rupture of the aorta, sometimes what we call aneurysmal rupture, which can actually lead to severe arm pain sometimes in some people. Same factors lead to blockage formation in the legs, which can lead to leg pain, ulcer formation, and a lot of those symptoms.
Other complications.
Same way, kidney arteries can also get similar blockage, which leads to what we call renovascular hypertension, or a type of high blood pressure which is very resistant to standard treatment. So it's the same vascular tree, same risk factors, and the treatment is more or less along the similar lines.
Right. So in nutshell, the blood vessels are getting blocked, and because the blood is not going, there is ischemia, and that's why we get the symptoms.
That's right.
So, as to narrate, the risk factors is more common in males, Asians, smokers, whatever leads high cholesterol, all those similar risk factors are same.
Yes, so risk factors are obviously very crucial. The traditional, the conventional thinking is it's more common in men, it's more common in smoker, it's more common when you have diabetes, high blood pressure, high cholesterol, and if you are of a certain age. Typically age greater than 70, but we start seeing this as early as age greater than 50, and I've seen patients even in their 40s.
Right.
Now, this is conventional wisdom. We have seen women with peripheral arterial disease. As a matter of fact, there is a recent research that came out, a paper published in Circulation, where they looked at peripheral arterial disease in Asian Indians.
Correct.
A very pertinent group that you and I both obviously are very familiar with. In Asian Indians, actually, PAD was nearly as common in women as it was in men.
Wow.
So, to say that women actually don't end up getting PAD is a misnomer. As a matter of fact, a type of circulation problem is venous disease.
Right.
where patients have varicose veins, they have
Correct.
leg swelling, they have
Right.
this big bulgy veins, which is way more common in
Right.
women and oftentimes a type of peripheral arterial disease.
Correct. So we see commonly varicose veins, especially with pregnancy and standing for a long time, obesity. So most women are aware of spider veins or varicosities. But when you talk about arterial disease, they kind of have no clue. So after the risk factors, let's go, how do they come to you? Because we know when the heart attack happens, the symptoms most people kind of know. How do they come to know about this leg pain? What is different, and how do patients present to you?
And that is the real challenge that, again, a lot of patients get the classic symptom. The classic symptom is the legs ache, and this aching can be multiple different times. It can be a very dull ache, it can be very sharp pain sometimes. A lot of people complain of burning.
Okay.
And this burning, or in Indian language they call it jalan or baratra, and that is actually very common from peripheral arterial and venous disease. Typically it affects one leg rather than both legs, but in venous disease we do see both legs getting affected. It classically typically happens when a person walks.
Correct.
After a certain walking, the pain would come, making them to stop walking, and then it gets better when you actually stop walking, compared to what we call neurogenic pain, which is
Right.
from the nerves, which typically happens when you start walking.
Correct. At rest.
So I always tell my patients, the leg pain can be one of the three things. It could be their plumbing, their gutter system, or their electricity.
Correct.
Plumbing pain is the arterial pain, gutter pain is the venous pain, and electric pain is the neuro pain.
Right.
And the plumbing pain or the arterial pain is in one leg, affects one muscle group, typically happens when you walk, stops when goes away when you stop walking.
Right.
Venous actually continuously present there. With swelling, gets better when you elevate your legs.
Correct.
It gets better. And the neuro pain is actually something that is there when you start walking right away, but
Right.
it gets better as you walk.
So my absolutely, I think, understanding is and the way to explain is similar. What I say that when you start walking, if it's a nerve, the blood supply gets better, so the pain gets less,
Right.
compared to vascular, when they start walking, the muscle is taking that oxygen. Now that oxygen cannot come as fast when there is a blockage, so that's why they get claudication. And then it's easy for them to understand why with walking and not walking, which absolutely is a similar explanation. So when you start walking, you're using your muscles, you're using that blood, and if it's a limited amount of blood, the symptoms are going to come. Now, does that give you some idea about the blockage, how much miles or how much distance they can walk?
Yes, absolutely. So when we hear this classic pain, when the way we describe it, that the medical term is claudication.
Correct.
For this exact type of pain. So when you hear somebody has pain which reminds you of claudication, it's peripheral arterial disease. You know that most people get that pain when their arteries are at least 70%, 80% tighter.
Wow.
A lot of cases, the main artery is 100% blocked. Now, one thing to remember is 1/3 of the patients, they don't get these classic symptoms.
Okay.
The pain is actually present even at rest.
Right.
And this pain typically happens at night time. When they go to sleep at night, they wake up suddenly middle of the night because their legs are aching, they're hurting. Some of this could be venous, but a lot of this is severe form of peripheral arterial disease when
Right.
they have a lot of blockage. They get this nocturnal discomfort. And the way they feel better is they actually get up and they dangle their feet, so the gravity actually helps with
The
some
blood
of this pain,
supply.
the blood
Wow.
supply, and they do end up feeling better.
But it's different than the Charlie horse you get at night. Sometimes during pregnancy you get cramping at night. Those cramps are slightly
and
different.
it does become a little tricky because
Correct.
a lot of time people cannot. So we always that actually probably brings to the next topic. But we always tell people any pain that's suspicious of peripheral arterial disease, to detect it is relatively easy.
Right.
It's always a good idea to get it checked rather than
assuming
that
it's just the
not.
Charlie horse.
Right.
So now they have this pain. Now you said the rest 10% might have different symptoms, or they might come with ulcers, right? Because the blood has become so less that it kind of makes it ischemia of the skin, and it's like an open wound there. So that some of the patients do come to you with...
Right, exactly. So again, to use the coronary artery analogy, a lot of people have like 70-80% blockage in the heart, and they get abnormal stress tests, and then they get fixed either with surgeries or stents. This is the example of the claudication, that the pain comes when you walk, you stop, and then gets better when you stop.
Correct.
when the disease progresses further, for example, in the heart, you get heart attack.
Correct.
When the artery is 100% blocked, what we call myocardial infarction, and the part of the heart gets scarred. Same way in the legs, the arteries get completely stopped and there is no blood flow at the tissue level.
Correct.
So the tissue oxygen level goes down, and very common in diabetic patients.
Right.
And they get these ulcers, which can be
very
very painful,
difficult to heal.
and they don't heal. It takes weeks to months to years sometimes.
Correct.
And that is the number one reason why people get amputation even in today's day and age.
Absolutely. So now we have the symptoms, the signs, we have examined these people. Now, before we go to, say, investigation like Dopplers, is there a clinical examination like by pulse? You can say that maybe this pulse is low or there is no pulsation. You diagnose PVD as well?
Yes. So all this, every person, especially when they have risk factors, should get their pulses checked in their routine doctor's visits.
Right.
A lot of time when they get to us as a vascular specialist, they already have absent pulses.
Right.
So it's important to check pulses, in the doctor's office, get them checked. We check pulses in their lower extremities, what we call femoral, popliteal,
Correct.
pedal
So behind
pulses.
the knees, just underneath your heel, there's the bones at the level of ankles. So those are very important points that
Very
should be
important
checked,
points, right.
because that tells you the level of blockage.
Right. We check the temperature of the skin alone.
Correct.
That tells us, if the skin is very cold and clammy. Sometimes the amount of hair on the legs tell you whether there has been good blood flow there or poor blood flow there.
Right.
Obviously, if you see an ulcer, we examine the ulcer, and depending on how the ulcer looks, the location of the ulcer, the duration of the ulcer it started,
Correct.
it tells us
I
whether
think
it's
we
from
used to
period.
have a question in surgery, how would you differentiate venous from, right? I think the straight cut, the deep
Exactly.
cut, and different kinds
Exactly.
of,
You see healthy tissues around it, or you
Correct.
see very unhealthy tissues,
So-
the color of the ulcer. And there's my pet peeve is when you see these people's legs that are very dark red,
Correct.
they're very congested. People think there is good blood flowing there. It's actually not.
No.
It's the collateral, it's the compensatory blood flow. So what we do in these people is when you take their legs from dependent position and you elevate up, the color completely fades and the leg
Right.
becomes suddenly white, and
Right.
that tells you there is a significant disease as well.
correct. So that's a good bedside examination to tell about how much is the level of blockage. We're going to continue with this talk in short time. Welcome back to Dr. Gor Show. So today we are talking about special kind of leg pain called peripheral vascular disease. It's an important leg pain because sometimes your health of your legs will tell you health about your heart. So pay attention. So far we've discussed that patients present with either leg pain or when they start walking it starts hurting them. Sometimes they have ulcers which don't heal. When they get examined, there's less pulsations. So now your medical doctor or your primary care have made this decision, and now they refer to somebody like a specialist like Dr. Shah, who is an interventional cardiologist practicing in New Jersey. So this patient has come from one of your friends, or this patient saw this show and came to you now. You suspected peripheral vascular disease after history and examination. What are the next level of investigations you like to do?
Sure. So when I see or suspect a patient with peripheral vascular disease, or they have symptoms or even simply risk factor, I focus on two things. One, the first one is how to help this particular person with their particular symptoms.
Correct.
Which is diagnosing and discovering if they have peripheral vascular disease, how bad the disease is, and what are some of the therapies we can do. But the second part of my focus is really how can we make their overall quality of life,
Correct, the lifestyle,
and overall longevity better, because again, people who have peripheral vascular disease have very high risk of cardiac events.
Correct.
I mean, this is, we always say leg is the window to the heart.
Wow.
So, when people have poor circulation in the legs, that tell us immediately that we need to focus on other part of the circulation as well. You can't just keep focusing on the leg and miss the
Absolutely.
other. So those are the two main things I focus on. As far as the legs are concerned, the very simple, the easiest of the first test is called ankle brachial index, which is getting blood pressure measurement in the legs. Just like the blood pressure in the arms that we measure, we compare the blood pressure at the ankle level and we see what happens. A very simple test. And when the blood pressure in the legs is lower than the blood pressure in the arm, it right away tells us there is circulation problem, there is poor circulation. Not only that, the degree of this drop in blood pressure, what we call the ABI, ankle brachial index, it tells us how bad the blockage is, where exactly the blockage is, how many blockages the person has, one leg, both legs, whether the blockage has calcium or not. So this is a simple 5-minute test in the office where we just check the blood pressure in different ankles. It's completely painless. It is highly accurate. It's almost 98% accuracy of this test. And it tells us all this wealth of information. So that's our first step.
Correct. So compared to heart, which sometimes can get difficult to figure out, and sometimes it's invasive testing to see the amount of blockage, this is relatively easy in the office, and it can be life-saving because that disease will tell us about the other areas as well.
Right. So that test actually tells us how bad the blockage is. A lot of people have minor blockage. They have minor decrease in their leg circulation and ABIs. And in those patients, we can just treat them with very simple medication, lifestyle modification, exercise therapy, all those things that we'll probably go over in a second. But if there is severe disease, if there is significant blockage that's altering their lifestyle, that they want to go to a shopping and they can't do it, they want to go to the mailbox and they can't even get the mails out, or if they have ulcer formation.
Correct.
Then we go to the next set of tests.
And usually in this country, they'll either say, I want to walk my dog, I can't go and walk my dog, and this kind of symptoms comes up. So after you've done the resistance index, do you look for the cholesterol profile if it's not been done? Do you look at other areas as well before we go into the therapy of PVD? Yes,
so absolutely. Once you discover and diagnose peripheral arterial disease, you have to assume that this patient has poor circulation everywhere.
Right.
So the focus as a cardiology is global. You want to make sure you protect them from getting heart attack, you protect them from getting stroke. Once you get peripheral arterial disease, your risk of getting heart attack or stroke or potentially dying from one of this is as high as 1 in 4, 25% risk. So it's as much risk as somebody who's diabetic and smoker and have family history. So obviously our focus becomes on that. So anytime I see a patient like this, I make every possible effort to bring their cholesterol level under control, which means initiating medication if they are not on it, or if they're on it,
alteration or dosage,
making sure they're okay. Same way there is a role of baby aspirin, just like cardiac disease. We put them right away on an aspirin 81, which actually works as a blood thinning medication and protects them from their legs getting, significant ulcers, amputation, all those things, and protect them from getting heart attacks.
Heart attack and stroke.
And strokes. And obviously, we look for, if they have any cardiac symptoms. A lot of these patients, they don't walk, they can't walk because of their PAD, so they don't get cardiac symptoms.
So their heart has not functioned to the optimum
Exactly.
amount.
So those things, obviously, we focus right away.
So either you'll do like a stress test, but they can't walk so much, so you can do chemical stress test.
Right, there are multiple ways, and we just start with basic EKG. We make sure there's no family history.
Correct.
And again, we look at their risk factors. We make sure that their blood pressure is completely under control, that diabetes is not through the roof. The primary prevention, the good things that all of us know, but
we don't implement it. Smoking cessation and all that stuff. So now you've diagnosed these people, and your first therapy was to start with aspirin, blood thinning. What are the other medical treatment which are available right now?
So obviously, again, depends on the blockage. For the traditional classic 70-80% blocked artery, there's a medication called Dr.Hetal or silastazole. That is one of the rare therapies which has actually proven to show improvement in their walking capacity, improvement in the circulation, and improvement in the distance they can walk, what we call the claudication distance. But more important than that is really exercise therapy.
Okay.
There is tremendous value of regular exercising. It's a paradox. The legs hurt so they can't walk. But more you walk, you are actually improving the disease. So we actually tell people to walk as much as they can until up to a point where their legs are literally aching and hurting. And
so you're pushing them to their limits.
You're basically recruiting blood vessels. You're telling your body that, listen, I'm going to walk whether you're giving me blood flow or not. More you walk, your body's going to form new blood vessels.
Correct.
And a lot of time this is very difficult because you need a lot of motivation. So we actually try to do that in a rehab setting. We send these patients to cardiac rehab.
So somebody's there monitoring them.
Somebody's monitoring them, there's somebody's encouraging them. And even if they can walk 50 meters more than their distance, their maximal distance, and keep gradually increasing this.
So you're making baby steps to kind of make sure they continue with the therapy of exercise.
Exactly.
So after exercise and
after exercise, aspirin, Pletal, and statin, these 3 medications and a prescription for exercise, these are 4 must anytime a patient walks in. Then obviously we have to look at really how bad the blockage is and what are some of the ways to open it up. Now, the traditional way to open the blockage until 6, 8, 10 years ago was bypassing this vessel.
Correct.
Where you go and you do this open surgery on the leg, where you take one of the veins from the other leg, or sometimes we used to use this plastic Gore-Tex graft, and you bypass the blockage, just like the cardiac bypass.
Right.
Nowadays, the therapy has majorly shifted. Majority of the blockage, I want to say 90 to 95% of the blockage, we can fix with endovascular therapies.
Correct. Similar to the stenting of the heart.
Similar to the stenting of the heart. The difference, however, is a lot of times you don't even have to put stents. You can just do a very good job with this special type of balloons where we can go and we can actually get the access in the wrist arteries, just like the cardiac blockages. We can get access in the other groin. Right. We can actually get access in the foot artery. And there are multiple ways of accessing this. And a lot of times these patients come to our office and we fix this in the office. Sometimes if it's bad, we have to bring them to the hospital. We fix the blockage and they walk home the same day in 2 hours.
And they feel great.
We open these blockages and, there is a tremendous improvement.
Now, does this blockage come back like heart disease if they don't, improve their lifestyle or they continue eating or smoking? Does this blockage happen?
So obviously, just like anything else, if one doesn't pay attention to the risk factor which led to the blockage formation in the first place, they can, there is always a risk of coming it back.
Correct.
But controlling the risk, if we keep them on a blood thinning medication, as I mentioned, if we keep them on cholesterol reducing medication, if they were a smoker and you help them quit, the risk of this coming back is less than 5%. So really very good chance that this will never come back. You need one treatment and you're done. A lot of times if they do come back, we can bring them and fix the same blockage again. Now what I like to do or what we like to do in between is once you fix a blockage, we don't let them just go. We actually do follow-up ultrasound. We check them with the ABI testing as well as ultrasound. We look at the areas we fix under the ultrasound. These are again non-invasive tests.
To make sure it's still pumping the amount of blood.
You make sure the blockage is not coming back, and sometimes you can even see that, okay, it's come back 20%, 30%, but no need to act yet.
Correct. So it's a nice way of explaining to the patient, here, listen, we fixed this, it's fixed right now. If you don't improve, this is going to come back, and maybe it's going to now affect the other areas like your heart and stuff where there are no second chances at times. So you better control it.
Yes, and you're right. So people who have blockage in one leg are oftentimes get blockage in both legs. Actually, the body is very symmetrical.
Correct.
I mean, majority of the time when we see blockage in one leg, even though one leg only hurts, we start seeing signs of blockage formation in the same exact artery in the other leg.
Wow. So now this is like a sign for them to, hey, listen, you have one sign, let's improve yourself. It's a red flag and take it. So we've discussed so much about peripheral vascular disease, and I think this kind of takes us into coronary artery disease, where a lot of things are similar. But here is an organ which is so important and it's so well protected. So treatment gets a little bit difficult, and I think we're going to do another show on that and explain. But thank you so much, Dr. Shah, coming and explaining to our viewers in such a simple terms. So all of you, I think this is kind of introduction to the arteries, which are the plumbing of our bodies, and if they get blocked, leg muscles, if you just start with that, which is not as essential organ compared to heart, but even that can affect your lifestyle so much, and it's going to, cause so much complication. When that happens, when your doctor is saying that you have some peripheral vascular disease, I think it's something that we should take it seriously and get it evaluated. And if we haven't controlled our diabetes, cholesterol, or not stopped smoking, I think this is kind of like a sign. Till next time, good night.